This is a case of a 40-year-old male, diabetic with uncontrolled hyperlipidemia, who first presented in October 2025 to us. On deep diving, he had a history of non-lifestyle limiting claudication, which was long-standing, of approximately 6 months duration, Rutherford category 1. However, when he presented to us in October 2025, he had a recent acute onset of increase in pain, tingling and numbness of the left fifth toe. On examination, there was no discoloration of the digits, motor and sensory reflexes were intact, and there was no tissue loss. The limb was otherwise viable. So based on the acute limb ischemia category, he was categorized as Rutherford category 1. Now we investigated him. His CPK-MB levels were normal, his WBC counts were normal, and based on his history, we advised for a CT angiography. The CT angiography showed a mid-SFA plaque in the left lower limb, causing approximately a 70 to 80% narrowing. And based on this, we took him up for a conventional angio with the aim to primarily treat him or revascularize. The DSA that was done in October 2025, it demonstrated an unstable SFA plaque. Now this plaque had some suspicious filling defects within, suggesting the probability of in situ thrombosis or a plaque rupture in an underlying chronic SFA lesion. Distally, 3-vessel runoff was maintained. However, there was a filling defect in the dorsalis pedis artery, which was likely embolic from the above SFA plaque itself. Now, based on these findings, we decided to adopt a wait and watch strategy, initiating a therapeutic anticoagulation dose with an antiplatelet therapy. So we started him on apixaban 5 mg BD dosage with a single antiplatelet ecosprin 75 OD dosage. The patient was advised offloading and instructed to monitor closely for any signs of tissue loss or impending ischemia, like blackening of the toes or a sudden increase in rest pain. Now we repeated a conventional angiography again at 3 months. This was in February 2026. This demonstrated a more stable SFA plaque. There were formation of collaterals. There was early venous opacification at the level of the plaque. All of these were suggestive of chronicity and plaque stabilization. In this slide, clearly we are seeing the difference in the plaque morphology on DSA. The image on the right showing a more stable plaque, the disappearance of the mottled or the filling defects, which were earlier seen in the angiograph of October 2026. There were certain collaterals as well as venous opacification, all showing signs of chronicity. Again, a delayed magnified view showing the change in morphology of the SFA plaque from October 2025 to Feb 2026, showing disappearance of the filling defects within the plaque and a more stable plaque as seen in Feb 2026, suggestive of chronicity. At this point, we were more comfortable going ahead with the intent to treat for this SFA plaque. So we proceeded with primary stenting of this SFA plaque without pre-dilatation to avoid cheesing of the plaque and distal embolization during stent deployment. So we placed a focal 5x40 self-expanding EPIC stent by Boston Scientific. These are again the images showing the primary placement of the stent, followed by post-dilatation with a 540 balloon, again done to prevent any distal embolization since the plaque was still initially thought to be an unstable plaque. So these are the slides showing the pre and the post images post the SFA stenting. So this case highlights that not all focal SFA lesions seen on the initial CT or the initial DSA may benefit from stenting during the index presentation. History and angio findings are key. On the history, if there is any history pointing towards an acute event, an acute onset increase in pain, tenderness or tingling, and the angio findings again showing certain filling defects, all these point towards probably an acute rupture of an underlying chronic SFA plaque. These may initially benefit from stabilization for the plaque with aggressive antiplatelet and anticoagulation therapy, and then waiting for up to 6 to 8 weeks for plaque stabilization, following with stenting at a later date after the plaque is stabilized.